Good afternoon, everyone. So my name's Collette. I'm a physiotherapist at Royal Prince Alfred Hospital, and I work within the Department of Respiratory and Sleep Medicine. And in particular, we deal with people who need help with their breathing involving non-invasive ventilation. We're also involved in the Forefront MND clinic, so this is an area definitely that we're quite interested in. What I'm going to talk about today, can you hear me okay?
All right, yeah.
What I want to talk about today is the effect that motor neuron disease can have on breathing, cough and sleep. And the reason why MND can affect these is often due to the MND causing weakness of the respiratory muscles. So we'll also have a look at some of the common signs and symptoms of respiratory muscle weakness.
Sorry, Collette.
That's okay.
I have a feeling.
We'll look at the common assessment tools we use to assess the respiratory system function. And finally, we'll look at some management strategies for dealing with breathing problems associated with motor neuron disease. So firstly, let's look at breathing. What's the primary purpose of breathing? First and foremost, it's to deliver oxygen from the air to our cells and tissues and organs for normal functioning, and to exhale carbon dioxide, which is a waste product from metabolism. And in order for those gases to exchange in the lungs, we have to get air all the way down the upper airway, the smaller airways, to these little air sacs at the very end of the airways, where there's a little blood vessel so that the oxygen can move into the blood and the carbon dioxide can move out. So it's important we get fresh air all the way down to those air sacs for that process to occur. Now, there's a number of important components of breathing. Firstly, we need the brain to send a message down the spinal cord, and this is via the motor neurons. So this carries the message to breathe to the respiratory muscles. The breathing muscles then have to carry out the message to breathe. And in order for this to occur, we need to have a patent or open upper airway so air can move in and out of the lungs. And we also need our chest wall and abdomen to be able to be moved by the respiratory muscles to draw air in and let air come out. And finally, the function of the lungs to allow oxygen and carbon dioxide to exchange between the lungs and the blood. So how can MND affect breathing? Well, we know that it causes progressive loss of motor neurons, and this can obviously occur in the nerves that supply the respiratory muscles. So there's a reduction in the ability to carry the message to the breathing muscles. The breathing muscles themselves can also experience progressive weakness and wasting. This can happen to all of the voluntary muscles, including the respiratory muscles. And when this occurs, it can reduce the ability to take a deep breath or do things like cough. MND can also affect the muscles in the throat, the bulbar muscles. This can have an effect on breathing. And a small proportion of people, even if their respiratory muscles still appear to be functioning normally, can still have an impairment in their drive to breathe, which can affect breathing. Now, respiratory muscle weakness usually develops gradually over time, but it can occur suddenly and often will have a variable rate of progression and timing as to when things start. Very rarely, that can be the presenting symptom that someone has prior to being diagnosed with MND. The muscles involved in breathing can be divided into two main groups. So firstly, the inspiratory muscles that help us to breathe in. The most important muscle here is the diaphragm. So this is a dome-shaped muscle, you can see just here. And the way that it works, when it contracts, it moves down, and that helps to draw air into the lungs. Now, the diaphragm also has some accessory muscles or helper muscles, so that if our oxygen demand or carbon dioxide production increases, for example, when we exercise, we'll often recruit these muscles to help us take deeper breaths and to breathe more. If there's weakness in these muscles, and in particular in the diaphragm, this can cause underbreathing, which we term hypoventilation or underventilation. Now, the other group of respiratory muscles are the expiratory muscles. When we're just sitting here breathing at rest, breathing out is what we call a passive process. So when we breathe in, our chest wall and our lungs get stretched as we fill up with air, and just the nature of those tissues recoiling back to their resting position enables us to breathe out. But sometimes we need to expire actively, and that's when we use these muscles, the abdominal muscles and some of the muscles on the rib cage, to help us move air out more quickly. Now, if there's weakness in the expiratory muscles, this can cause a weak cough and may make someone prone to developing chest infections or even pneumonia. So the way that, we'll just go back to cough. What's important to have an effective cough? First of all, we need to take a deep breath, fill our lungs up with air, and then we close our glottis or our throat, and that's to build up pressure inside the lungs. And then we quickly open the glottis or the throat and forcefully expire using our expiratory muscles to force the air out and clear whatever's in our airways. So MND can affect any or all of these processes. If the breathing in muscles are weak, it can be difficult to take that big breath in to start with. If the bulbar muscles are affected, there can be difficulty in coordinating or closing those muscles to build up pressure inside the lungs, to have that just prior to that expulsive phase. And if the expiratory muscles are weak, it can be hard to push the air out quickly. So that can cause difficulty with coughing or an impaired cough. Now just talk a little bit about sleep. So sleep is really important. We need sleep to regulate our hormones, to repair and to repair cells and to grow, to lay down memory or consolidate memory, and a number of other factors. So it's a really important process and we really can't avoid it. We can divide REM up into two main stages: non-REM, NREM, and REM, the REM. So REM sleep is called rapid eye movement sleep, and that's where we have most of our dreams. The important thing about REM sleep is that it's a good thing, so we don't act out our dreams, but all of the voluntary muscles, or the muscles we have control over in our body, they all relax during REM sleep, except for the diaphragm and the muscles around the eyes. So what this means is that if your diaphragm is weak, breathing can be a problem in this stage of sleep. So even though sleep is a state of rest, it places a load on our respiratory system. There's a number of changes that occur. Our drive to breathe changes, the depth of breathing changes, the muscles we can recruit changes. So in REM sleep, you can't recruit those accessory muscles to help you breathe. Our upper airway is not as patent. And our arousal responses from sleep are dampened, particularly in REM sleep. In the absence of disease, we've got plenty of reserve, so we can cope with these changes. And generally, there's little change overall in our breathing from going to awake to non-REM sleep to REM sleep. And this means that our oxygen and carbon dioxide levels can remain stable. So we're getting enough fresh gas down to those little air sacs to exchange oxygen and carbon dioxide. However, if the respiratory muscles are weakened, that means that there's a reduction in the reserve that we've got to cope with this load from sleep. This can cause a reduction in overall breathing, which tends to get worse as you go from wake to non-REM sleep to REM sleep. And what this can look like, it can cause less oxygen going in and less carbon dioxide going out, meaning the carbon dioxide levels can rise. So in this example, this is the oxygen level here, and this is the carbon dioxide level. And you can see there's dips in the oxygen and the carbon dioxide's going up where that person is under breathing. So initially this often starts in REM sleep, and then over time, if not treated, it can then affect breathing during non-REM sleep. And you can see the level of oxygen dipping down gets worse and the carbon dioxide going up gets higher. And then eventually it can start to affect breathing during the day. And if carbon dioxide levels are what we call chronically elevated or persistently elevated above normal, that's termed daytime respiratory failure. And this is associated with a reduction in both quality of life and survival. Now, the signs and symptoms of respiratory muscle weakness, it's important to realise that often problems occur during sleep before symptoms appear during the day, and with breathlessness, for example. And the kind of things that people might notice with their sleep is that it might be disturbed or they're feeling non-refreshed. They might feel sleepy during the day, have trouble concentrating, feel confused, have headaches in the morning or during the night, and feel fatigue. Now, some of these are nondescript symptoms. It's important that we put this all together with a full respiratory assessment. But just some things to think about where you might need to talk to your respiratory specialist. When breathing is affected during the day, the most common symptom people will describe is breathlessness. And this might start during exertion. So, for example, I used to be able to walk, from one end of the block to the other, but now I feel breathless when I do that. So feeling breathless where previously you didn't. And then that can also occur when you're at rest, or things like bending forward to tie shoelaces, submerging your chest in water. Even talking and having a conversation can induce breathlessness. And this other funny word, orthopnea, that simply means feeling breathless when you're lying flat. Now, the reason why those activities might evoke a sensation of breathlessness is all to do with the diaphragm. So if we're bending forwards and tying up shoelaces, remember the diaphragm contracts down to draw air in. We're crunching the diaphragm, pushing the tummy contents up and restricting it. And if it's weak, it's hard for it to contract down. If we're in a body of water covering our chest, that water exerts pressure on the chest wall and the diaphragm has to work harder to push out. So the symptoms of breathlessness and orthopnea are what the person feels. We can also look for signs, which is what other people can see. And you might see someone who's breathing faster and more shallow than normal. They might be using their accessory muscles to breathe. So, for example, the muscles around the throat. If I start to breathe quite deeply, you can see marked change in the muscles that I'm activating. And you might see the chest not expanding as much as usual. So that was to do with the inspiratory muscles. Just switching to the expiratory muscles for a moment. Some of the symptoms people might have are having recurrent chest infections, and this may be due to having a weak and ineffective cough, not clearing secretions properly, which can turn into an infection. With regards to assessment of the respiratory system, this is something that ideally is performed early and regularly. And the idea being that we want to detect early signs of respiratory muscle weakness. And this is in order to discuss the use and the best timing for offering some breathing support, and this is usually something called non-invasive ventilation. The respiratory team also needs to or wants to optimise the management of any pre-existing lung conditions, like asthma, for example. And it can also be important to assess respiratory fitness for having procedures, for example, insertion of a PEG tube or feeding tube, and also air travel. Does anyone know why air travel, particularly long-distance flights, can have an effect on your respiratory system? No? So when you're... yeah? Exactly. Exactly, yeah. So when you're at altitude, the air pressure is reduced, and even though the cabin is pressurised, at sea level we're breathing around about 21% oxygen. In the air cabin it's about 15% oxygen. So for all of us that have normal lung function in the absence of disease, we've got a big reserve, we can cope with that. If you're someone who's got some respiratory muscle weakness, that might be a difficult process. So sometimes there's some planning involved in how to reduce risk and make this achievable for you. It's also important having a respiratory assessment regarding getting an idea of prognosis and to assist with planning for the future. So when we assess the respiratory function, respiratory system function, there's a number of things that we do. Firstly, doing some breathing tests, and we often look at the maximum volume of air someone has in their lungs, the strength of the breathing muscles, and this can involve a number of tests. One of them is called the sniff test, which looks a little bit funny. It's a little bung we pop in the nostril and get people to sniff, and that gives us a really good idea of particularly how the diaphragm is functioning. We also measure cough strength, and that's as simple as coughing into a mask, and we can measure the amount of flow that someone can generate. And we've got levels at which we know we need to introduce some strategies to help with cough. Occasionally a blood gas test might be required, and this is taking a sample of blood either from an artery, or sometimes we can take it from an earlobe if we warm the earlobe. And that's that's the gold standard test for measuring exactly what the carbon dioxide level is. So those tests are looking at what's happening during the day. It's also important to think about what's happening at night. And we'll do things like something called oximetry, which is measuring the oxygen levels overnight during sleep, or sometimes even a sleep study might be required. So a sleep study measures lots of things about your brain activity. So are you awake, are you asleep, what sleep stage? And lots of things about breathing to try and characterise, is there a problem, and if there is, what is that problem during sleep? So I'm now going to move on to management strategies. Firstly, some general strategies to try and reduce the risk of respiratory infections, because prevention is always better than cure. We always recommend patients to have the flu vax every year, and if you can, avoid people who are unwell and perform good hand hygiene. So really simple stuff there. If any problems with eating, drinking and swallowing are noticed, try and see a speech pathologist as soon as possible to have a swallow assessment. They may recommend modification to diet, swallowing techniques, etc. Because we want to avoid food or drink going down into the lungs and causing a bad infection. Regarding breathlessness, if orthopnea or breathlessness lying flat is a problem, to avoid that position, and positioning someone using a wedge or pillows or an electric bed or in a supported chair in a more upright position can often make breathing more comfortable. Using a fan, now this probably sounds a little bit like snake oil, but it actually can work quite well. So there's some receptors around our nostrils and around our middle third of our face, where if you pass over cool, dry air, so a little handheld fan like that, you can get them from eBay or the Lung Foundation sell them, can help to reduce the sensation of breathlessness. And it's a nice intervention in that it has very few side effects. Even if you put the fan on your face, they're foam, so it's not going to cut you. Avoiding large meals can also help with daytime breathlessness if it's associated with eating. And the reason being, the stomach is located just under the left hemidiaphragm. So if your stomach is really full, again, it's hard for the diaphragm to contract down. So having smaller, more regular meals may help there. Relaxation, meditation, and regulating the temperature or humidity in the room can help. So often if the air's hot and humid, people may have difficulty breathing. Having an air conditioner on, if you've got that, may help. And pacing and conserving energy, breaking up a task that you know is going to cause breathlessness. So I'll now move on to non-invasive ventilation. So this is recommended when there are signs or symptoms of sleep hypoventilation or underbreathing, or daytime respiratory failure. And we always try and start non-invasive ventilation earlier rather than later. So what is non-invasive ventilation? Well, it's a small machine that pushes air into the lungs via a mask, and the idea being to help you take deeper breaths. So it's getting more fresh gas down to that gas exchange area of the lungs, the little air sacs. There's higher pressure breathing in and lower pressure breathing out. It's something that's usually applied during sleep, although some people may go on to need to use non-invasive ventilation during the day as well to manage breathlessness. This is an example of the two main brands of machines that are available. Improve quality of life as well. Now, in this particular study, it was a randomised controlled trial, which is the most robust study design when performing clinical studies. The survival benefit was observed primarily in people without severe swallowing problems. However, there's been some subsequent studies that it appears that if we start non-invasive ventilation early in people with bulbar symptoms, that they too can perhaps derive a survival benefit as well. So this is something that we do offer to everyone. The other effects that NIV can have is it can improve sleep quality, improves oxygen and carbon dioxide levels, it can prevent or reduce sleep disordered breathing. Now, it's not just underbreathing that can occur with motor neuron disease. Upper airway obstruction or closure of the upper airway can occur during sleep as well, and NIV can treat that too. And all of these symptoms and some of the signs that we talked about earlier non-invasive ventilation can help to alleviate quite a number of those symptoms. There are some potential side effects with NIV. So if using a mask that sits on the nasal bridge, there's often not a lot of tissue between the nasal bone and there's just a bit of skin over it. So it can take a bit of time to get used to wearing a mask. Now, if there's a bit of tenderness over the nasal bridge, there's dressings that we can use to provide a bit of extra padding. However, if left unchecked, occasionally a pressure area might develop. Now, we try and prevent this from occurring by swapping to a different type of mask that doesn't sit on the nasal bridge, for example. And the other thing that people may describe is getting a dry mouth. So when the machine delivers pressure to you, it's got a little flow generator that generates quite high airflow, so it can be a little bit drying. Often we'll use something called a humidifier to add a bit of extra moisture into the air that's being delivered. Now, if someone had a lot of thin secretions, they might not want to have the humidifier, and the NIV might help to dry things out a little bit. Having a sip of water can also help if dryness is a problem, or there are some oral lubricant products, for example, biotin, which may help with that dryness as well. Some practical considerations with NIV. Often people will need assistance to use the mask and the machine, so it's important that the carers are educated how to use the equipment as well. And from a safety point of view, we have to make sure that someone is able to call out for help or to notify someone if they need help when the NIV mask is on. Regarding the type of mask that we choose and who's with the person when they're using NIV, if someone is with them, might dictate the type of mask that we use. The machines I showed you beforehand, they're not what we call life support devices, so they're really meant to be used overnight during sleep, up to maybe a couple of hours during the day. Now, if a person was using non-invasive ventilation and going above 12 hours a day, and certainly if someone was up to 16 hours a day, we would switch their equipment to life support ventilators that have a battery in them. There's 2 devices, just to make things safer. So if someone was in that position, we'd recommend going back and talking to the respiratory and sleep team that prescribed, and maybe reviewing the plan of action. So how do you access non-invasive ventilation once it's been prescribed? This is a different answer compared to this time last year. So as of October this year, NDIS have circulated that they will be supplying respiratory equipment. Previously they didn't because that came under health. We're yet to see how this actually plays out, because I think there's a lot of administrative infrastructure that hasn't really been teased out yet as to how that's going to work. But this may help people to access equipment that they may have had difficulty accessing previously. Presumably this would have to be written into care plans and have funding available. The other thing that NDIS allegedly will provide are cough assist machines, and these have been really hard to get previously, so that's potentially good news for those where NDIS is accessible. For the short term, often hospital or clinics might have a loan pool of machines. We do at our centre, and we can loan people equipment whilst they're getting set up. The other option is to privately hire. The best deal at the moment, you're looking at around a little bit less than $150 for the first month and $100 thereafter, and then $25 a month to hire the mask. From a long-term perspective, and even people who are receiving NDIS funding, the New South Wales State Government program Enable New South Wales, at this point in time, will still continue to provide non-invasive ventilation devices to anyone who meets the eligibility criteria within the state. And generally, to get funding through Enable, you need to have a 4-week trial of non-invasive ventilation at home. So it needs to be obviously indicated for you, for someone to be using it at home, deriving benefit. And we tend not to bring people into the sleep lab because that can be a bit disruptive. We can do some monitoring of oxygen levels at home. Provided everything looks okay, we submit an application. So what does this cost going through the government program? They ask people to contribute $100 per annum. If you're on a higher income, at worst, they would ask you to contribute 20% of the state contract price of the device, which at this stage is a bit less than $400. And there's also options to, in the long term, privately hire or privately purchase devices. But there are some limitations to using NIV in people with MND. So unfortunately, not everyone can tolerate non-invasive ventilation, and I think around 25 to 30% of people in some of the trials that have been conducted have trouble tolerating NIV. And this might be due to claustrophobia, it could be due to severe bulbar dysfunction or weakness of the throat muscles. In addition, NIV doesn't stop disease progression, and it may not be beneficial in the very advanced stages of disease. Eventually, the breathing muscles may become too weak for someone to breathe adequately, and that's where it's really important to have a good respiratory and palliative care plan or an advanced care plan or directive to really articulate what an individual's personal preferences are for comfort and quality of life. The alternatives for managing symptoms, and breathlessness tends to be a key symptom that people describe with respiratory muscle weakness. There are some medications that can help, for example, benzodiazepine medications or anti-anxiety medications. And the opiates or morphine-based drugs are very good at helping to alleviate breathlessness. These can be prescribed through the consultant neurologist, palliative care physician, respiratory physician, GP. And importantly, they can be used alongside NIV. So it's not an either or. Sometimes I think and can work quite well. People often ask, what about supplemental oxygen? Is this something that can help? And generally it's not recommended because it doesn't address the primary problem caused by weakened breathing muscles, and that is underbreathing. And there's a risk of making carbon dioxide rise even more if inappropriately high levels of oxygen are delivered, because it can depress breathing. But it may have a role if someone has pre-existing lung disease or has a chest infection, for example. So I'm now going to move on to talk about cough and some of the strategies we can trial to see if that can improve the efficacy of cough. So firstly, a manually assisted cough. Now, if the breathing out muscles, expiratory muscles, are weak, remember these muscles are trying to force air quickly out of the lungs. So if we apply pressure to the abdomen, doing an abdominal thrust, or if that's not comfortable, doing an overpressure on the chest when someone is trying to cough and breathe out, that can force the air out more quickly and make the cough a bit stronger. The other thing that we commonly do in our patients with motor neuron disease and also other neuromuscular diseases where the respiratory muscles are weak is something called lung volume recruitment. So this is actually a resuscitation bag that has a one-way valve, so air can only go to the patient, not back. Little bit of tubing and attached to a mouthpiece or a mask. So this is also called breath stacking. And what it does is we get the person to breathe in the biggest breath that they can, and we literally stack one breath on the other until the lungs are filled up with air. Now that alone, because it's stretching the chest wall and the lung tissue, can help to make exhalation faster or make the cough stronger. And we can superimpose doing an overpressure or a manually assisted cough with that to make the cough stronger. Lung volume recruitment, in addition to helping with cough strength, can also be quite good at stopping the chest wall and lungs from getting a bit stiff if someone's breathing at low lung volumes. Probably the best tool that we have to help with making a cough stronger is something called mechanical inexsufflation, or a cough assist machine, which you can see in the picture here. And the way that the cough assist machine works is via a mask. It delivers positive pressure on the way in, so it helps the person to take a big breath in, and it can deliver negative pressure on the way out, so it helps to suck the air out quickly, simulating a cough. These devices usually can be quite hard to come by. Some hospitals will have them and use them in the acute setting only. They can be rented from the Philips Sleep Easy centres, but now NDIS can fund cough assist machines, but they'd have to be written into the plan. And I think they're around about $10,000, so they're not a cheap piece of equipment. Enable New South Wales recently performed a pilot study, and we were one of the trial sites. We're waiting for that data to be, all the final follow-up data will be finished towards the end of the year, And then hopefully, we're very hopeful that it will become a regular piece of equipment that we'll be able to request through Enable New South Wales as well, which will help with equity across particularly people who can't get NDIS funding. Now, with these techniques, they may not work in everybody, and particularly people with significant bulbar dysfunction or weakness of the throat muscles. Sometimes these strategies may not be effective or as effective. There are ways we can modify things to try and make them as effective as possible. So again, it's something that we always trial. And the kind of people that can introduce these techniques are usually physiotherapists who have specific experience dealing with respiratory and people with neuromuscular disorders. So not every physio will know how to do this. So in summary, the main respiratory consequences of motor neuron disease are respiratory muscle weakness, sleep disordered breathing, and respiratory failure. Having input from the respiratory team early is important so that we can have early detection of respiratory muscle weakness to assist with planning and introduction of appropriate management strategies. We know non-invasive ventilation can be a very important tool that we have to improve survival and quality of life in people with MND. And there's also, not to forget, the expiratory muscles and cough. There are some techniques we have available to assist with that as well. And we like to, introduce these reasonably early so that people can master them on the occasion if they do develop a chest infection. So I'll leave it there. Does anyone have any questions? So what the opiate medications are very good at reducing the sensation of breathlessness. A side effect can be depression of breathing, so you're absolutely right. And that's why there's very careful titration of the dose. And usually things are started at really low doses and seeing how someone responds. So with a lot of medications and interventions, there are side effects, and it's about weighing up symptom alleviation versus any side effects and trying to get it right. So breathlessness can also evoke anxiety, which is very understandable, and so having. I beg your pardon?
Which makes more
Exactly. And breathlessness is quite a complex sensation. It's multifaceted. It's not, it doesn't always mean oxygen is low. It can be due to a number of things. So having a multifaceted approach can be quite beneficial. But you're absolutely right. It's something we have to be careful about.
Thank you for that question.